Hello, everyone. A very good afternoon. My name is Dr. Jason Lim. I'm a senior consultant obstetrician and gynecologist at the Department of O&G here in SGH. As shown in the video earlier on, the Department of O&G here in SGH delivers a wide range of gynecological services, including that of the maternity services, and we have a well-equipped labor ward as well. Welcome to today's public forum on endometriosis, period pain goes away, and endometriosis health talk. Some of you may be aware of this condition known as endometriosis, but for those who are not so aware or may not have heard of this condition before, there is this talk that there's a lineup of speakers, and we're going to cover the following areas. What is endometriosis? By Dr. Andy Tan. He's going to share with us what endometriosis is all about. What are the treatment options for endometriosis, shared by Dr. Lim Hui Hui. What has sex got to do with endometriosis? This will be touched on by our senior physiotherapist, Ms. Ip Wan Hui. And lastly, endometriosis and its impact on fertility, which will be covered by our IVF specialist, Dr. Serene Lim. So without further ado, let's dive straight into the talk itself. And our first speaker is Dr. Andy Tan. He is a consultant at the Department of Obstetrics and Gynaecology. He is also the chief clinician in the area of endometriosis and minimally invasive surgery in our department. It is a good friend of mine and has a wide range of expertise in terms of experience with endometriosis after his fellowship training in a very prestigious, renowned endometriosis referral center in Denmark a couple of years back. So without further ado, I would like to introduce Dr. Andy Tan to deliver his talk. Dr. Tan, the floor is all yours.
Thank you very much, Jason, for your kind introduction. All right, I would like to take this opportunity to thank Bayer and SGH comms team again for organizing this public forum to raise endometriosis awareness. So before I delve into the subject of endometriosis, I would like to discuss, is it normal to have painful menstruation, painful period? So painful menstruation, also known as dysmenorrhea, is one of the commonest women's problem. And most women begin to experience painful period during adolescence and usually within 4 to 5 years of the first menstrual period. So dysmenorrhea can be categorized into primary or secondary. So when there's no underlying pathology or abnormalities found, so it's called primary dysmenorrhea. So what are the causes? Usually, it's defined as the prostaglandins, chemical that produce in the lining of the womb, causing the muscle contractions. And there's a nervous sensitization due to abnormal ratio of this prostaglandins, resulting in inflammatory process and uterine vasospasm and ischemia. So what are the treatment for primary dysmenorrhea? So as defined earlier, usually there's no underlying pathology. Usually a simple analgesic such as Panadol or NSAIDs will help. And usually the pain should not last more than 24 or 48 hours and it should not be progressively getting worse. And usually self-resolving as mentioned earlier, and you should expect improvement after pregnancy. Of course that you can still use birth control pills to treat primary dysmenorrhea and sometimes other complementary therapies such as heat pack, exercises and yoga. So if there's no response or worsening of symptoms, we should consider secondary causes. So at this point, a detailed clinical history is required to identify any underlying causes. So this includes a detailed history, the history of a pain which can be accounts of timing and the severity of the pain, a pelvic pain and other associated symptoms such as deep pain during sexual intercourse, any previous history of a pelvic inflammatory disease or sexually transmitted infection, any bowel habits changes or bowel symptoms that can reflect as inflammatory bowel symptoms, previous abdominal or genital tract surgeries, for the risk of adhesion. This will follow by a clinical examination and relevant investigation. So physical examination will include abdominal and pelvic examination to exclude any pelvic masses, and followed by ultrasound pelvis to rule out any uterine fibroids, adenomyosis, or endometriosis. So here, what is endometriosis? So endometriosis is a condition where the tissue similar to the inner lining of the womb, called endometrium, is found elsewhere. This is usually found around the womb, the place called uterosacral ligaments. It's a fibrous band behind the womb. It can be on or behind the ovaries and on the fallopian tube. It is a common and benign condition, usually affecting 1 in about 10 women. Usually affects women during their reproductive years and regress during menopause and pregnancy. It is an estrogen-dependent disease that induces abnormal bleeding and inflammation, leading to scarring and adhesions. It is a long-term condition that can have significant impact on women's general physical health, emotional well-being, and daily routine. So what are the symptoms when someone has endometriosis? Usually, they may present with painful period affecting daily activities and quality of life. Sometimes can be associated with irregular or heavy period, deep pain during or after sexual intercourse, period-related or cyclical pain related to the bowel movement or when passing urine, chronic pelvic pain, lower back pain radiates to the top of the thigh, long-term fatigue, infertility. Other symptoms. So some women with endometriosis may not have any symptoms. Some experience regular pattern pain, becoming worse before and during period. Some experience pain all the time, but for others it may not come and go. So what really causes endometriosis? This is still a myth. The exact cause of endometriosis is still not known. But the very famous and accepted theory is what we call a retrograde menstruation. Other theories such as lymphatic or vascular spread, this is a direct spread, or coelomic metaplasia where the peritoneum causes the changes and becomes endometriotic cysts or tissues, immunohormonal dysfunction, or genetic predisposition. So this video is to illustrate the theory of retrograde menses. So from this video, there is a reflux of the menstrual debris containing viable endometrial cells through the fallopian tubes into the pelvic peritoneum, causes a deposition of this endometrial tissues. And this endometriosis, the endometrial tissues will continue to grow. So the ectopic endometrial-like tissues located outside the womb will respond to the hormonal changes and bleed together during menstrual period. This bleeding can cause pain, inflammation, scarring, and possibly damage your pelvic organs. Endometriosis may be found on the ovaries, as mentioned earlier, and in the fallopian tubes, in the peritoneum or the bladder, in the area between the vagina and the rectum, can also occur within the muscle. This is termed adenomyosis, and occasionally on the bowel and bladder. It may sometimes be found out of the pelvis, but it's rare. So these pictures show us this degree of endometriosis from peritoneum to severe endometriosis, such as endometriosis on the ovaries, or we call endometriomas, and deep infiltrating endometriosis you can see in this picture involving the bladder and the womb, causing scarring. So everyone wants to know what are the risk factors for having endometriosis. So the known endometriosis risk factors are early menarche, or we call it early onset of menses, late menopause, short menstrual cycles, and being nulliparous means not having children before, heavy or prolonged menstrual bleeding, there's obstruction of menstrual outflow, and family history, particularly a mother or siblings having a previous history of endometriosis. So how is endometriosis diagnosed? Diagnosis can be difficult at times because the symptoms of endometriosis vary. Some women have no symptoms, and the severity of pain does not correlate well with the severity of the stage of the disease. There's no specific biomarkers to detect or to rule out endometriosis, and the symptoms of endometriosis can be similar to the pain caused by other conditions such as IBS or PID. And furthermore, it's not uncommon to have the misdiagnosis for a period of time before the endometriosis is diagnosed. Furthermore, the delay is due to the lack of awareness and the stigma or symptoms normalization. So I'd like to thank that actually Bayer with us come up with this protocol and information leaflet to assist physicians and the patients to identify any symptoms that are related to endometriosis. So what will happen when you see a gynae? So if you suspect you have any endometriosis related symptoms, when you see a gynae, you'll be asked about any pain that you may have, whether is it has a pattern or is it related to anything particular to your period. About your periods, are they painful and how heavy are they? Whether you have any pain or discomfort during sex, and about problems with your bowels and urinary symptoms at the time of the period, and about any difficulty trying to get pregnant if you have one or more of the symptoms that I mentioned earlier. What would you expect when you see a gynecologist apart from the history taking? So your gynae may carry out an internal examination with your consent. This helps to localize the pelvic pain and allow the doctor to feel for any lumps or tender areas. The chaperone will be present during this examination. And tests, usually a pelvic ultrasound will be carried out, and this is by mode of transvaginal scan to look for any endometriosis on the uterus and ovaries. It may show whether there's chocolate cyst in the ovaries, suggestive of endometriosis. This is an ultrasound typical of endometriosis. We call a chocolate cyst for ground glass appearance. Sometimes MRI pelvis may be required to identify endometriosis, such as this deep infiltrating endometriosis behind the womb and in front of the rectum. However, a negative findings does not exclude endometriosis. So if a negative findings is there, but the symptoms suggest endometriosis, sometimes the diagnostic laparoscopy may be required. I will not go into the extent of the stage of the endometriosis, as my colleague will be talking about it later on. But clinically, it is important to know whether the endometriosis is involved in the peritoneum, whether it involves the ovary, or is it deep infiltrating endometriosis. So what are the treatment options available? And my colleague, Dr. Lim, the next speaker, will also be going through with you the treatments available. But generally, it's categorized into conservative, hormonal, versus surgical treatment. The treatment should be customized to each individual depending on the presence of the pain and the severity of the pain, the size of the endometrioma, whether you have desire for fertility, and the patient's age, any recurrent endometriosis. So why is it important to raise awareness? As I mentioned earlier, endometriosis can happen in adolescence. However, due to the delay in diagnosis, women have to suffer until the adulthood to have the diagnosis the endometriosis diagnosed. And you can see from here that the delay in diagnosis can lead to the productivity loss as well as the healthcare society impact. So in the conclusion, endometriosis affects 10% of women in the reproductive age. The economic burden exceeds $22 billion in the USA alone, and more than 176 million women have diagnosis of endometriosis worldwide. The disease recognition is still inadequate, and the diagnosis time ranges from 4 to 11 years, with 65% of women being initially misdiagnosed. It is observed up to 70% of women with pelvic pain, up to 50% women with infertility. If you experience worsening of pelvic pain, to suspect endometriosis. And endometriosis is a chronic condition, and long-term management plans should should be sick. And seek treatment early if you experience symptoms suggestive of endometriosis. Thank you.
Okay, thank you very much, Dr. Andy Tan, for the very wonderful and comprehensive coverage on what is endometriosis. I understand from the Q&A panel, there are questions already coming in. We'll leave the questions right at the end. Meanwhile, if any of the speakers or the experts would like to just key in your inputs on the various questions, please feel free to do so. But of course, in terms of the questions-wise, we'll take it to the end. And now we move on to the next segment, which is what everybody is also waiting for. What can you do about endometriosis? So today we have Dr. Lim Hui Hui, who is an associate consultant in our Department of Obstetrics and Gynaecology. She has a special interest in endometriosis, minimally invasive surgery, as well as reproductive medicine. And without further ado, let me hand the floor over to Dr. Lim Hui Hui. Dr. Lim Hui Hui, please. Thank you.
Thank you, Dr. Jason, for the kind introduction. And today I'll be talking to you about what steps you can actually take to treat endometriosis. And I always feel with anything, we should always start from the beginning. And this is often the simple step of just being aware. Here's a survey that was conducted by the Endometriosis Group in the UK. And this was a survey done for over 2,900 women in 2011. And the survey showed that on average, it took about 7.5 years to diagnose endometriosis. And women actually had to wait for nearly 2 years before they visited their doctors about their symptoms. Subsequently, a referral to a specialist then took an average of 4 years, and a further 1 year and 9 months before a formal diagnosis is made. So this means that more than 5 years can pass before a woman gets diagnosed of endometriosis. And this means more than 5 years of unnecessary pain and unnecessary suffering about symptoms, and the symptoms are often unacknowledged as well. What we want to do is stop this from happening. And how we can do this is to actually educate both the public as well as the physicians. And this is through the use of public forums such as this one today. We also conduct GP educational talks and webinars to highlight that endometriosis is chronically underdiagnosed, and let the GPs know as well what can be done to actually increase awareness and improve diagnosis. We also reach out through newspaper articles as well as social media to further spread the word. The next step to actually treating endometriosis would be to recognize your symptoms. We do know that endometriosis is a disease that has a significant impact on a woman's life. As my colleague Dr. Andy has mentioned in the previous presentation, the most common symptom is the experience of painful periods. And pain can also be experienced outside of the menstrual cycle as well, resulting in chronic pelvic pain. Some may present in a very non-specific ways, such as fatigue and a lack of energy. And others may present with painful bowel movements or painful urination during menses itself, pain during or after sex, and some are even seen in our fertility clinic with difficulty getting pregnant. I put up here a QR code of endometriosis symptom quiz, which can also be found in our local endometriosis support group. And this is a very short quiz that you can actually take to see if you could have endometriosis. The next step to diagnosing and treating endometriosis would be to take the leap and actually seek help. And this is often the step, unfortunately, that women take years to actually make, as they think, especially in our culture, that painful menses is normal, but it is not. And women should stop being told that actually painful menses is normal. Here are some ways that you can help to actually prepare for your appointment to make full use of your consultation. Firstly, you could keep a pain or a menses diary, and this allows you to track your symptoms throughout the month and shows us how your symptoms actually vary and whether anything actually helps to make it better or worse. You could try writing down any points or any issues that you wish to discuss during the consultation, or any burning questions that you want answered in your consultation. Have a list of your medications that you have taken previously, any side effects you've experienced, any medication that you're currently taking now. And if you visited any doctors or had any hospital admissions, it will be good to also bring along the discharge summaries or any letters. Last but not least, don't be afraid to ask questions. Doctors, we do tend to give a lot of information in a short span of time. And in our endometriosis clinic in SGH, we try to allocate more time per patient, especially for new cases, so that we can elicit more information and explain the condition better. But the important thing is to understand that do not be afraid to ask questions and that we are here to help you. So please do not leave our clinics more confused than before. The next step to treating endometriosis would be to actually understand our treatment goals. And this is what we as physicians hope to achieve with you. So we hope to manage your symptoms so that we can improve your quality of life. We hope to preserve function, so for those who wish to get pregnant or fertility, and those who are experiencing painful sex to allow you to have sexual intercourse. We want to excise the disease to prevent the risk of recurrence and the need to repeat the surgery again, as well as for better symptom control generally. I will talk about the next step, which is treatment options, in the next few slides. But before I do that, there are some pertinent points that I wish to highlight to you before we go into the details. Firstly, it is very important to understand that even though there is no cure for endometriosis, there are a number of ways to treat it. And endometriosis does regress after menopause as well. And as we are speaking, more research is being done to actually discover new ways to diagnose as well as to treat endometriosis. Treatment will vary between women to women, and this is depending on your priorities as well. So for example, if you're trying to get pregnant, then we may not be able to use hormonal medications on you to help with the endometriotic symptoms. And my colleague, Dr. Serene, will speak to you more about endometriosis and fertility in a later talk as well. And the decision for treatment will be based on several factors, and you should discuss this closely with your doctors and decide on the treatment in partnership with them. So the decision should be based on various factors such as your age, how severe your symptoms are, and whether you have had any side effects from previous treatments and whether they have worked for you. So for treatment options, we divide them into two, which is medical as well as surgical. So for medical, we have the pain-reducing medication, analgesia. And we have a disease-reducing medication, which tends to be hormonal medications. For analgesia and hormonal medications, they should be used simultaneously to help with the treatment of endometriosis. For surgical options, there's conservative as well as radical surgery. So I'll briefly talk about the difference between those two in the next slide later on. So if we look at medical options, which is analgesia, we tend to use non-steroidals, otherwise known as NSAIDs. And this, for example, would be the ibuprofens, the mefenamic acids. And what it does is that it actually helps in the management of pain and inflammation caused by endometriosis itself. We find that women with endometriosis, they tend to produce an excess of prostaglandin, which is this hormone-like chemicals that can be found in the cell of every body, in the cell of every of the body, basically. And high levels of these prostaglandins can cause inflammation and pain. And since non-steroidals work to actually block the production of these prostaglandins, they should be taken before these chemicals are actually produced. In other words, you should start taking this medication at least 24 hours before you expect to experience the pain, and you should take them regularly during these painful periods as well. One of the medications that we use very frequently, which is a hormonal medication, is the combined oral contraceptive pill, the COCP. It is a low-dose synthetic estrogen and progestogen, which is a female hormone. And what it does is that it suppresses ovarian function and inhibits the growth of endometriotic implants. For birth control purposes, we usually prescribe them every month with a withdrawal bleed for a week after. But for endometriotic patients, what we suggest would be to take them continuously or in 3-monthly cycle with a week of withdrawal bleed after. Barring any contraindications, the COCP can be used as a long-term medication. And for those women who do not wish to get pregnant, they are also a very good form of contraception or birth control. Other benefits of COCP also include reducing the risk of endometriotic as well as ovarian cancer in the long term. Another hormonal medication would be progestogens. And there are multiple forms of administration for progestogens. You can put them as an implant on the underside of your arm, and this can last for 3 years. You can give a 3-monthly injection. You can take them as a daily pill as well. And you can also insert them into, it's as an intrauterine device, inserted into the uterus, and this can last for 5 years. What it does is that it inhibits the inflammation pathways and causes suppression of the endometriosis. The side effects, however, depend on the type and the form of the progestogens used, and they can include things like vaginal spotting, bloating, breast discomfort, fluid retention, etc. It is also very important to remember that the side effects depend on the type of progestogen, and the response to the therapy also vary between women. So if one type of progestogen does not work for you, another type might just do the trick. They also have a lot less contraindications compared to COCPs and can be used long-term for suppression as well. Another medical option which we use as a second-line treatment would be a GNRH analog. So the growth of endometrium and endometriosis is dependent on some hormones, one of which is a GnRH hormone. So what we do is that the GnRH analog blocks the action of GnRH and stops ovaries from being stimulated and producing estrogen, and therefore the endometrium and the endometriosis do not grow. Because it temporarily stops the woman from producing estrogen, it will put her in a temporary menopausal state. So the side effects of this medication are those experienced by some menopausal women, such as hot flushes, night sweats, irritability, etc. And although it is very effective, usually if treatment is continued for more than 6 months, we will add back some hormone replacement as well to ensure that bone thinning does not occur. For surgical options, we aim to actually reduce the symptoms of endometriosis by removing endometriotic implants. We aim to also remove endometriotic cysts with care so that we can conserve the ovarian tissue as much as possible. And this is to prevent subfertility or premature menopause in the future. We also want to remove any adhesions and to correct any distorted anatomy for symptomatic control. We will also send off these tissues for histology to confirm the diagnosis and to rule out any cancer. And also we want to have a detailed description of what we see in the pelvis and where the sites of endometriosis are so that we can stage the endometriosis appropriately as well. Conservative surgery would include the removal of any visible nodules, the removal of any endometriomas, which are cysts, and the removal of adhesions to restore normal anatomy. However, the recurrence rate post-surgery can be quite high for endometriosis, and it can be 20% in 2 years and even up to 50% within 5 years. Hence, we actually recommend to use hormonal therapy after operation to reduce the risk of disease recurrence. For deep infiltrating endometriosis, which are nodules that can be implanted on the bowels or implanted on the urine tubes, we are very fortunate in SGH to have the support of our urology as well as colorectal colleagues to actually form a multidisciplinary team, hence making surgery a lot safer as well as more effective for the patient. For radical surgery, this applies to women who have failed any medical or conservative management but are still experiencing very severe symptoms, or women who are actually already close to menopause and wish for a more definitive treatment. This will include the removal of the uterus, which is the womb, tubes and ovaries, any deposits, as well as to restore normal anatomy. However, with removal of the ovaries, this will result in menopause. For those who wish to do so, there is an option of hormone replacement therapy as well. For surgical options in our center, we have laparoscopic, which is keyhole surgery. We have the help of a robot as well, which is also a keyhole surgery, which is minimally invasive. But the robot actually helps to get deep into the pelvis so that we can do deep infiltrating endometriosis and clear them as much as we can. And of course, there's an open surgery as well. However, for endometriotic surgeries, we tend to do them minimally invasive, which is laparoscopic or robotic. So on the left is a picture of a laparoscopic surgery where you use small instruments and small cuts to actually do the surgery. And on the right is a recent picture of us as an endometriosis team using our newest robot in SGH to perform a surgery for a patient with deep infiltrating endometriosis. So the final step, after you've been made aware of your condition, you have recognized your symptoms, you have taken the leap and sought help, you have also understood our treatment goals, and you have discussed your treatment options with your doctor. The final step would be actually to find support. Remember, you are not alone in this. As my colleague mentioned, 1 in 10 women are diagnosed of endometriosis, meaning there are a lot more out there who haven't been diagnosed at all, and finding support can help make living with this condition a lot easier. And also understanding endometriosis better through the right channels can let you take control of your condition and your life. There are local support groups such as the Singapore Endometriosis Support Group, which you can sign up for and find out a bit more information about it. And there are also international support groups in which you can seek more information and help. Finally, before I end off my session and I hand over to the next speaker, it is important to remember that endometriosis is a chronic condition, so there is no magic bullet to actually solve this problem. However, we do know that it has a huge impact on a woman's life. Although unfortunately, it is often underdiagnosed. But we feel that times are changing, and as more women step up to say that they have this condition, it can no longer be ignored. Finding out which treatment is suitable for you can be a trial and error process, so be patient before you find out which one works for you. So let us walk with you and help you with your condition. Thank you.
Thank you, Dr. Lim Hui Hui, for the very excellent and overarching coverage of the various options and alternatives of management in endometriosis. Thank you very much. And next, we're going to cover a bit more on endometriosis and what has that got to do with intercourse or sex. And this will be covered by Ms. Ip Wan Hui, our senior physiotherapist at the Department of Physiotherapy at SGH. So Ms. Ip actually obtained a graduate certificate in the pelvic women physiotherapy from the University of Melbourne many years ago. And she advanced in the Masters in Incontinence and Pelvic Floor Physiotherapy from Curtin University about 2 to 3 years back. So she's none other than the best person to talk to us and share with us on this topic of endometriosis and painful sex. Ms. Ip, the floor is all yours.
Thank you, Dr. Jason, for that very gracious introduction. Hello, everyone. So thank you for joining me in this segment on endometriosis and painful sex. As introduced, I'm Wan Hui and a pelvic health physiotherapist. So this might be the first time you have heard of the term pelvic health physiotherapist. So please allow me to explain what pelvic health physiotherapy is about before I begin. Pelvic health physiotherapists work predominantly with muscles in and around the pelvis. You might have heard of the pelvic floor muscle. This is the main muscle that we work with. So if you look at this diagram on the right, the pelvic floor muscle will be that muscle at the bottom of the pelvis here in red. We are familiar with physios being helping people reduce back pain and helping people back on their feet after a surgery or a stroke. So what exactly does a pelvic health physiotherapist do? We help people with pain in and around the pelvis, and that includes helping people who have pain during sex. We also help people to regain control of urine, stool, and gas, and help people with difficulty emptying their bladder and bowel. Now that we have a better idea of what pelvic health physios do, let's move on with the talk. I'll be sharing on the link between endometriosis and painful sex, the role of pelvic health physiotherapists in the management of painful intercourse, some things that you can try at home if you experience painful sex, and provide some resources at the end. About 1 in 2 women diagnosed with endometriosis report having pain with sex. But not everyone with endometriosis has painful sex, where each woman feels pain with sex is different as well. This pain can be felt during or after sex. Before we go further, I want to let you know that help is available. Nobody should have to put up with painful sex. In fact, continuing to have painful sex can worsen the situation. So what are some of the reasons that sex can be painful for women with endometriosis? The most common reason listed if you do a web search is the stretching of endometrial tissue. Penetration and movement can cause stretch on endometrial tissue, causing pain. Therefore, where each woman feels pain is different because the endometrial deposits are different in everyone. But typically, this can be felt as sharp or dull pain that is deep within the pelvis with movement during sex. However, stretching of the endometrial tissue is not always the cause of pain. Because if it was, then every woman with endometriosis will have painful intercourse, but that is not the case. A common reason why women with endometriosis have painful sex is vaginal dryness. Hormonal treatment is often used to manage symptoms of endometriosis, and these treatments can sometimes lead to vaginal dryness with prolonged use. Women can also find it difficult to achieve arousal and produce sufficient natural lubrication because of pain or because they are worried about feeling pain. The discomfort vaginal dryness causes can be felt as a pulling or friction causing sharp pain and can result in difficulty achieving penetration. As we know, the main symptom of endometriosis is pain in and around the pelvis. One of the body's natural reaction to pain is tension. The muscles surrounding the vagina and pelvis can tense up because of this pain. Sometimes these muscles do not relax even after the pain has subsided. During sex, the tense muscles may be stretched, causing pain. The pain felt can be close to the surface if the tense muscles are near the surface of the vagina. Or it can be deep within the pelvis if the tense muscles are within the pelvis or around the hips. If painful sex occurs regularly, the brain can recognize sex as a painful and potentially dangerous activity in a process called sensitization. This results in you feeling pain when there is touching or stretching around the vagina. This can also cause the muscles to tense further without your knowledge when you attempt to have sex, causing more discomfort. This is why continuing to have painful sex can worsen the situation. Here are the common modifiable reasons why sex can be painful. Tense pelvic floor muscles or muscles around the pelvis. Sensitive vaginal skin that can cause pain with touching and stretch. Vaginal dryness resulting in friction and discomfort. Stress, anxiety, and poor sleep. These increase muscle tension and vaginal dryness. Irritable bladder or bowel conditions can cause increased sensitivity in the muscles and tissue in the vagina. And fear of pain, which also contributes to muscle tension and vaginal dryness. As you can see, these factors are linked to one another. So, how does a pelvic health physiotherapist help someone experiencing painful sex? Well, we act as detectives, finding out the unique combination of factors that is contributing to the pain in each woman and work together to reduce pain with sex. If muscle tension is present around the pelvis, we introduce stretches such as those seen here. If the muscles around the pelvis are tight, they can cause pain within the pelvis and even increase tension of the muscles in the pelvic floor. This is why we pay attention to the muscles around the pelvis as well. Gentle stretching can also be done for the muscles in the pelvic floor with the fingers or with the help of these vaginal dilators seen here. For those who have increased tissue sensitivity around the vagina, where touch and pressure on the tissue feels painful, we will guide them on how to reduce the sensitivity with self-massage and stretching. Vaginal dilators of increasing sizes will be used to help the tissues to stretch gently without triggering pain. For ladies who experience vaginal dryness, we provide education on the different types of lubricants so that they can select the type that is right for their use. Water-based lubricants are the most common ones, and these are not expensive, but they can dry up quickly, requiring top-up, or it may end up feeling sticky instead. Silicone-based lubricants cost more as compared to the other types, but last longer. Oil-based lubricants or natural oils such as coconut oil can be used as well, but these can stain the sheets. However, because oil-based lubricants are water resistant, it can be used in the shower without being washed away. For those with irritable bowel or bladder issues contributing to painful sex, hydration and dietary advice will be given by us. If needed, a dietitian will be involved. Relaxation techniques will be introduced for ladies struggling with stress and anxiety. This is because stress can increase muscle tension in the body. And there are free applications such as Smiling Minds that we use that are very, very useful for this purpose. While working on reducing tissue tension and sensitivity, pelvic health physiotherapists will also work with you on the ways to maintain intimacy with your partner without painful penetration. Depending on your comfort level, your therapist may invite your partner to attend the session with you so that they understand the situation and you can work together as a team towards pain-free penetration. If the services of other members of the healthcare team is needed to enhance your recovery, you may be referred to them. These include, but are not limited to, sex therapists, dietitians, and counselors. We will now move on to some things you can try at home if you experience painful sex. The most important one must be to communicate with your partner. Sharing about your condition and educating them about your pain helps your partner to understand. This removes guilt for both parties and helps to prevent any misunderstanding. Working as a team with open and honest communication helps as well. Talk about what is pleasurable for both parties that doesn't cause pain. Start with that to maintain intimacy while therapy helps you to work towards penetration if that's something both you and your partner would like to achieve. Strategies to pace and position yourselves can help you to achieve pleasurable penetration. Pace yourself by taking time to relax and set up for pleasurable physical intimacy. This does not need to include penetration if you are not ready yet. Everyone is different. For some, a warm shower is enough to help them to relax. For others, strategies such as listening to music, having a massage, or practicing mindfulness are more effective. Going through the strategies your therapist taught you about relaxing and stretching your pelvic floor can be helpful as well. When you feel relaxed, you can engage in any touch that is safe and pleasurable. Pain-free foreplay and outer course helps to achieve satisfaction and confidence to take the next step. Using some lubricant can go a long way in helping to make things more comfortable during foreplay and sex. Just remember to select the correct type of lubricant that fits your purpose and avoid scented lubricants as these can potentially irritate the vaginal skin. Prior to engaging in sex, practice saying slow down or agree on a safe word so that your partner knows when to slow down or stop. Try different positions as well, especially those that allow you to take control of the depth and speed of penetration. These are typically positions where the lady is on top. Some ladies find that sex might be more comfortable at specific parts of the cycle. So try at different times of your cycle. You can create a diary and this will allow you to identify patterns more easily. Start with slow, gentle penetration and progress as you are comfortable. There are some wearables designed to reduce depth of penetration that you and your partner can try. So this one in particular is actually made of soft stretchable silicone rings that can be stacked or removed according to your comfort and your progress in terms of penetration. If you're experiencing painful sex and will appreciate some help, get your doctor to refer you to a pelvic health therapist, in some places known as women's health therapists. And you may also be referred to a sex therapist if needed. For helpful information on pelvic pain for both men and women, you can visit the Pelvic Pain Foundation of Australia website. This website offers free educational information and has a list of helpful stretches that you can try at home. This is an interesting podcast designed to educate about endometriosis. So it's not just interesting for yourself, but you can actually use this podcast to educate your partner and your family members to help them to understand your condition better. Last but not least, this is an interesting book on female sexuality, worth reading to improve your sex life, whether or not you're experiencing pain. With that, I've come to the end of my talk and would like to acknowledge Diane for her contributions to the content that I've shared today. And thank you very much for listening.
Thank you very much, Ms. Ip, for all the important vignettes on sexual health and endometriosis. We will now move on to our next speaker, Dr. Serene Lim, who is a consultant in the Department of Obstetrics and Gynaecology. She is an IVF specialist in the area of reproductive medicine with special interest in endometriosis and the effects of endometriosis on fertility and what can we do about this. Without further ado, please allow me to introduce Dr. Serene Lim, and she will bring us through. Dr. Serene Lim, the floor is all yours.
Hi, Jason, for the kind introduction. Hi, so I'm Serene. I'm one of the consultants from SGH ONG, and I also work in the Center of Reproductive Medicine. So today I'll be talking to you about endometriosis and infertility. Endometriosis and infertility can be a bit of a complex and controversial topic. So some of you with this issue might have seen a doctor and have come out of the clinic a bit confused and not knowing what to do. And this is perfectly common. And some of you perhaps might have seen more than one specialist and realize that different doctors do not always agree on your treatment. This is also fairly common. So I hope that today I can give you some basic information, touch on the controversial issues, and hopefully provide some clarity about this. All right. So we know for a fact that endometriosis can cause infertility. And in fact, infertility is very common in women with endometriosis. Not all women with endometriosis will have infertility, but about 30 to 50% of women with endometriosis will have difficulty conceiving. In fact, about 1/3 of these women have what we call silent endometriosis, meaning that they don't have any symptoms and they do not even know that they have endometriosis until they do a fertility check. A fertile couple in their first year of trying will have about 15 to 20% monthly chance of conceiving. But in women with endometriosis, the chance of getting pregnant per month can be as low as 2 to 10%. Endometriosis can be graded into 4 stages of severity. Most women have minimal mild endometriosis, where there are just superficial spots and very mild scarring. So you can see in this picture, this is mild endometriosis, where there's some mild endometriotic spots in the lining of the pelvis. So these patients usually have mild or no infertility, and they do very well with either fertility surgery or assisted reproduction. Now, this is moderate endometriosis, where the disease is more extensive and there may be chocolate cysts in the ovaries. So take note, once you have chocolate cysts in the ovaries, it's not considered minimal or mild disease anymore. Automatically, it's graded as at least moderate endometriosis. And there is severe endometriosis, which means that the endometriosis is actually invasive. It eats into the tissues around the womb. So you can see on this picture, here's the womb, okay, and next to the womb are your other organs like the intestines. All right. So the endometriosis actually eats into the tissues around the womb and causes inflammation. And sometimes it even goes into the intestines. Normally, there is a clear separation between the womb and the intestines. They are completely different organs. But in severe endometriosis, there's extensive scarring, or what we call adhesions. So this can cause the bowel to be so stuck to the womb with essentially no clear separation between the two. So operating on severe endometriosis is in fact one of the most challenging surgeries. So you should choose your surgical team wisely. It's not only just difficult to operate on these patients, but it is also quite difficult to get them pregnant, even with fertility treatment. So as the severity of the endometriosis increases, the degree of infertility increases, and the less successful fertility treatment will be. So all things equal, usually the patients with minimal mild endometriosis will find it easier to get pregnant as compared to those with severe endometriosis. Endometriosis can occur anywhere in the pelvis. So you can see this round ball is the ovary, which contains the eggs. The ovary releases an egg every month, all right, and then the egg goes into the tube. So the tube actually catches the egg and it directs the sperm to the egg. So essentially the tube is like a meeting point for the sperm and the egg. Once the pregnancy is conceived in the tube, it is transported into the womb where implants. Endometriosis can affect fertility in many ways. Essentially, endometriosis is an inflammatory condition, and the body reacts to the inflammation by forming scar tissue. The scar tissue distorts the anatomy of the reproductive organs and affects their functioning. So the picture on the left shows a normal female pelvis. So the womb is in the middle, and you can see the ovaries. The ovaries are the white balls with the tubes here, hanging freely at the sides of the womb, and you don't see any scar tissue at all. This picture on the right shows severe endometriosis. So there's like extensive scarring that causes the ovaries and tubes to be pulled to the center as if they are kissing. And they are also stuck to the back of the womb and the bowel. So this can affect the function of the tube such that it's not able to catch the egg properly or help to transport the sperm to the egg. So the picture on top shows an endometriotic nodule that is sitting on the outer surface of the tube. Sometimes endometriosis can also occur on the inside of the tube itself. So you think of the tube as being a pipe with a lumen, okay? And sometimes endometriosis can occur inside and essentially cause the tube to be like mechanically blocked and swollen with fluid. So you can see this is like a tube that is swollen. This is an endometriotic cyst in the ovary. It looks like chocolate, so we call it a chocolate cyst, and is surrounded by ovarian tissue, which contains your precious eggs. So you can see the chocolate cyst being surrounded by the ovarian tissue and containing your eggs. The chocolate cyst can cause production of inflammatory substances and free radicals, which damage the surrounding ovarian tissue and is toxic to the eggs. So this affects the hormone environment of the eggs and results in poor quality of your eggs. There's also direct damage to the eggs and causes a lower egg count. Endometriosis can cause inflammation in the womb itself, and this can affect implantation of a fertilized egg. And lastly, it can result in painful intercourse and reduce the frequency of sex. You will have heard from my colleagues that the standard treatment of endometriosis is either use medications to suppress the inflammation or surgery to physically remove or burn away the disease. But patients who wish to get pregnant need to have a different approach. Painkillers don't help to improve fertility, although they can help you to manage your pain. Although hormonal medications are very effective for pain reduction, most of these medications work by preventing ovulation and stopping your periods. So if you are taking these hormone medications long-term to help with your pain, you won't be able to get pregnant unless you stop the medications. So the two main approaches to endometriosis-associated infertility would be assisted reproduction or surgery. Very often, couples would be offered options of surgery or IVF or test tube baby. Unfortunately, I must confess that neither treatment option is perfect. So this is a table that I made comparing the benefits and disadvantages of surgery versus IVF. So it's a very busy slide, so I'm going to walk you through it. So the green points are benefits and the red points are the disadvantages. So firstly, how does surgery help? So surgery itself can be part of the infertility workup. In patients with minimal or no symptoms, it can help to confirm the presence of endometriosis, and it can also help to check if your tubes are blocked. Endometriosis affects fertility by making the environment harmful for an egg or an embryo. So surgical removal of endometriosis could help to create a more favorable environment for successful conception. After surgery, the chance of spontaneous pregnancy is increased for the next 12 to 18 months. At the same time, the surgery will hopefully have helped to treat your endometriosis pain, so you can concentrate on trying to get pregnant in a pain-free state without needing to take hormone medication. If you ever need to go for surgery to treat endometriosis, I would suggest that after the surgery, you try hard to get pregnant. Don't give the endometriosis a chance to come back. If you're not ready to start a family, then consider taking medications to prevent recurrence. Endometriosis is a very unforgiving disease. So if you don't do anything about it, chances are it will return and cause more damage to your fertility. Now, what about IVF? IVF works very differently from surgery. So what we do in IVF is that we'll give the woman injections to help her to develop mature eggs. In an IVF cycle, ideally we aim to get at least 10 to 15 eggs. Eggs are collected during a non-surgical procedure, and we fertilize the eggs with the sperm in the laboratory. The fertilized egg or the embryo is transferred back into the womb. So, unlike surgery, IVF does not directly treat the endometriosis, and it would not relieve pain from endometriosis. So it's purely a fertility procedure. But what IVF can do is that it can overcome some of the harmful effects of endometriosis on fertility. In IVF, the sperm and the egg meet in the lab, so it can help to overcome tubal damage caused by endometriosis. Most women would ovulate just 1 egg per month in the natural cycle. So each month that you try naturally, you only have that 1 egg to help you to get pregnant. But each time we do an IVF cycle, we can collect at least 10 to 15 eggs in women with a normal egg count. So the chances of finding that golden egg that will give us the baby are multiplied by doing IVF. Generally, IVF would shorten the time to conceive. This is important for patients with endometriosis because many of them suffered from chronic pain. But once they are pregnant, these women would be quite free of their endometriosis pain because pregnancy and breastfeeding can help to suppress endometriosis. So by helping these women to get pregnant faster, IVF can help these women to be pain-free quicker. The other advantage of IVF is that IVF can also treat other infertility factors. So if the woman is older, or she has a low egg count, or if her husband has poor sperm, then IVF is generally advisable. And lastly, compared to surgery, IVF generally is less risky in terms of complications. So if IVF has all these advantages, then why don't we do IVF for all endometriosis patients? So apart from relieving symptoms, the other benefit of surgery is that it can remove a large chocolate cyst. So when there's a large chocolate cyst in the ovary, surgery would usually be considered as the first option. There are a few reasons for wanting to remove cysts. Rarely, these cysts can be cancerous. The larger cysts would usually pose more concerns with cancer, so it's better to remove them to confirm. And when there's a large chocolate cyst in the ovary, it may also get in the way of retrieving eggs during IVF and reduce success. So it's better to take out the large cyst before you do IVF. And if the patient gets pregnant with a large chocolate cyst, there is a small chance that the cyst can burst like a balloon and leak chocolate fluid near the womb. This can affect the pregnancy, and the woman may even need to go for emergency surgery, which would be risky to the pregnancy. There's usually no need to remove smaller chocolate cysts because the small cysts don't usually pose a problem, especially if they are like less than 3 to 4 centimeters. 5 to 6 centimeters, a bit controversial. I guess you can consider them a bit borderline in terms of size to cause any problems. Most gynecologists would suggest to remove cysts that are at least 7 to 8 centimeters and above because these are considered quite large. So the management of these chocolate cysts can be quite controversial. On one hand, they can cause problems for the pregnancy and IVF and rarely may even be cancerous. But on the other hand, removing them would usually cause the egg count to drop on the operated ovary. So the decision as to whether to remove a chocolate cyst or not is really like being stuck between a rock and a hard place. If you keep the chocolate cyst, it can cause problems like coming in the way of your egg collection during IVF, and also potentially causing problems during pregnancy. But on the other hand, if you remove the cyst, it can cause damage to your egg count. There are 2 reasons why the egg count is reduced after remove a chocolate cyst. So firstly, when we take out the cyst, this is the cyst here, and this is your normal ovarian tissue. So when we take out the cyst, there would be some normal ovarian tissue that would frequently be cut out together with the cyst. So some eggs would be lost. So this is the picture on the right side, which shows how the ovary looks like after remove the cyst. After remove the cyst, usually we will see some bleeding on the ovarian tissue that is left behind. We have to stop the bleeding, all right? So after remove the cyst, usually we would apply a bit of heat energy on the ovary to stop the bleeding, and this would destroy some eggs. This can be minimized with surgical technique, but even in the most experienced and gentlest of hands, there would inevitably be some drop in the egg count. So if the woman undergoes IVF later, she might need more medications to develop her eggs, and she might have low numbers of harvested eggs. The impact is not so significant if she has a good egg count to start with. The other ovary would usually be able to compensate. But in older women who tend to already have a low egg count, or in women who have had cyst surgery before, doing another surgery on the ovary can be very damaging. So other advantages of surgery. So surgery is a pure endometriosis treatment. So if there are other fertility factors like poor sperm, you are better off doing IVF. And lastly, we cannot ignore the fact that surgery carries a risk of surgical complications, including injury to the bowel, the bladder, and even the kidney tube. And in the most serious of endometriosis cases, where the bowel is like really stuck to the back of the womb, like super glue, the risk of bowel injury can go as high as 10%. So you can see in this picture, this is the womb here, and this is the bowel. So both are really are practically stuck to each other. So essentially, I think treatment of endometriosis-related infertility needs to be individualized. So this chart is a summary of the different factors that you need to take into consideration when you decide what treatment approach is best for you. Our main priority is symptom relief, or if you wish to give yourself a chance to get pregnant spontaneously, then surgery would be a better option. But if you have other infertility factors, like if you are on the older side, or if you are known to have a low egg count, or if your husband is known to have an issue with his sperm, or if your priority is to get pregnant faster, then IVF would be more suitable for you. If you have a large chocolate cyst that your doctor is concerned might be cancerous or might cause problems during pregnancy or egg collection, it may be better to try surgery first. But if you have had previous surgery in the ovaries, I would be very cautious about suggesting repeat surgery because that can really damage the egg count. So surgery and IVF are not perfect solutions on their own. Surgery on its own would not be able to treat other infertility factors like age, poor sperm, etc. And IVF as a means of achieving pregnancy is unable to overcome all the negative effects of endometriosis on infertility. IVF cannot help to improve your egg quality, and it may affect implantation. It cannot improve your implantation. So the next question is, can surgery and IVF be complementary to each other? Would it be a good idea to combine both options, essentially to get the best of both worlds? So some of you might be waiting to do IVF. Would surgery to remove endometriosis and its inflammatory effects before IVF help to improve success rates? I think the answer is that generally surgery is not routinely recommended before IVF for all endometriosis patients. And in fact, in cases of severe endometriosis, removing the deep infiltrating endometriosis disease hasn't been shown to increase the IVF success rates. And on the other hand, it might actually cause surgical complications. But there may be a few situations where you can consider doing surgery to help with your IVF cycle. So for example, if you have a large chocolate cyst, or if you have tubes that are swollen. If we transfer an embryo with a swollen tube present, the chance of successful implantation of the embryo is halved. The reason is because the fluid in the tube can go into the womb and wash out the embryo, or is toxic to the development of the embryo in the womb. So taking out the swollen tube before IVF can improve the pregnancy rate. If you have had IVF done before and the egg or embryo quality was poor, some doctors believe that egg quality can be improved by removing endometriosis and inflammation from the ovary. Or if you did manage to make good embryos, but they failed to implant, some doctors believe that implantation can be improved by removing endometriosis and inflammation from around the womb. So all this is very controversial. So instead of doing surgery, can we perhaps use medications like Progestogens or GNH Analogs as an alternative way to suppress endometriosis before IVF? So I think medications, if taken short-term, can be useful. If you are doing your IVF cycle in a public hospital like SGH or KK or NUH, you probably know that there's a wait list for IVF and you have to wait a few months before you can start your cycle. So medications can help you to manage your endometriosis pain while waiting to do your IVF cycle. Also, by reducing inflammation for the few months before you start your cycle, the medications may help you to have better eggs, better embryos, and better implantation when your cycle starts. On the other hand, medications may have some side effects. For example, GNRH analogs can cause hot flushes, dryness, and long-term use can reduce the bone density. Some doctors also believe that long-term use of medications can suppress production of implantation factors in the womb lining and perhaps make it less receptive to the embryo. Now, how about IUI or artificial insemination? IUI is a more natural way of conceiving. So what we do in IUI is that we will give the woman some medications. So either we give her oral tablets or low-dose injections to get her to produce 1 to 3 mature eggs. We will give her an injection to release the eggs. So the eggs are released into the body. We don't need to do an egg collection, unlike for IVF. The day of ovulation, we get a husband to come down to our center to produce the sperm. We wash the sperm and we put the sperm in the womb. So in IUI, the sperm and the egg meet in the tube, like what happens naturally. Whereas in IVF, the sperm and the egg meet in the laboratory. So patients who are more suitable to do IUI are those with good fertility factors. So for example, those with just minimal or mild endometriosis, or if the woman is younger, the husband has good sperm, and at least one tube is patent. You can also consider doing IUI in addition to trying naturally after you have had endometriosis surgery. So I'm going to go through case examples of two patients. So this first patient is 35 years old. She was trying to conceive for about 2 years, and she's got severe menstrual cramps, not better with painkillers. Her husband's sperm is normal, and when we did an ultrasound, we saw that there were 4 chocolate cysts, about 2 centimeters each in the left ovary. Her right ovary was normal, and her egg count was on the high to normal side. So let's weigh the pros and cons of each option. So surgery will help with her symptoms, treat her endometriosis, and increase her chance of spontaneous pregnancy. But there is a risk of operative complications, and there are concerns with reducing the egg count. The good thing is that in this lady, her egg count was on the higher side of normal to start off with. So with careful surgical technique, she should still be able to maintain a decent egg count after surgery. So eventually, she did surgery and she got pregnant spontaneously a few months later. So this is my second patient. So this lady is younger, she's 26 years old, and she's got severe endometriosis. She already had a cyst operation a few years ago to remove an endometriotic cyst on her right side. She's trying to get pregnant for the last 2 years, and her husband's sperm test is normal. She has been in and out of hospital with severe pain from her endometriosis, and her scan unfortunately now shows that the endometriosis has come back with a small cyst of about 3 centimeters in one of her ovaries. So her scan also shows that there's also deep infiltrating endometriosis, and her egg count is low. So we've had a long discussion with this patient. One of our priorities for this patient was to get her pregnant as quickly as possible because she has been suffering from the pain of endometriosis. Although surgery may be able to relieve her of her symptoms, we felt that it was an inferior option because her egg count is already low from the previous cyst surgery. So it's best not to cause further damage to her egg count by doing a second operation. Repeat surgery for endometriosis also carries higher chance of surgical complications like injury to the bowel and the kidney tube. And lastly, the endometriosis has recurred after the previous ovarian cyst surgery. So if she were to undergo another operation, the chance of the endometriosis coming back is very high. So in the end, the patient chose IVF. Despite maximum stimulation medications, she only had 8 eggs collected at egg collection. For someone who is 26 years old with a normal egg count, we would expect 15 to 20 eggs. So her egg count was much lower than expected for her age. The good thing about this patient was that because of her young age, she still managed to make good embryos. And this can help to compensate for the effects of endometriosis. And eventually she got pregnant in her first IVF cycle. So I think to conclude, endometriosis negatively affects fertility through multiple mechanisms. Management of endometriosis-associated infertility requires consideration of multiple factors. So it's not like a one-size-fits-all kind of treatment. I think we cannot ignore the impact of other factors in determining success of fertility treatment for endometriosis. Female age is a major factor in determining pregnancy success with endometriosis. So the younger you start trying, the better. Firstly, because younger age means better eggs. So this can help to undo some of the fertility damage caused by endometriosis. Secondly, endometriosis is a progressive disease. So it's better to start trying early than to wait until the disease has progressed to the severe stage. Once endometriosis has reached the severe stage, it would be harder to get pregnant. So lastly, optimizing lifestyle factors and taking care of your general health is also important. Lifestyle choices like maintaining a normal weight, reducing alcohol, and avoiding smoking are important. Increasing the frequency of sex will always help. If you want a baby, you cannot just have sex on weekends. So I'd like to provide, if you need some more information, I'd like to provide a QR code which you can access to look at our IVF assisted reproduction pamphlet. You can also download our hospital's Health Buddy app. The Health Buddy app does have a link that contains information on many gynecological problems, including endometriosis, infertility, and infertility treatment. And for those couples who are thinking of doing IVF, if one of you is a Singaporean citizen, you do get some funding from Ministry of Health. So this is the QR code that links you to find out more information about that. This is the end of my talk. Thank you.
Okay, thank you very much, Serene, Dr. Serene, for the very, very insightful, very comprehensive, and yet succinct talk. I believe that is challenging always when it comes to endometriosis in the realm of fertility and how do we manage these cases. And I believe, and I concur with Dr. Serene that, all this has to be tailored individually, depending on the degree, dependent on the symptoms, the severity of the endometriosis that one has. So thank you, Dr. Serene. And again, it gives me a lot of great pleasure to have with us today Dr. Astrid, who is a consultant at the Sengkang General Hospital, who will share with us and who has kindly agreed to share with us her journey with endometriosis. Dr. Astrid, please.
Okay, hello everybody. I hope you all can hear me. So, my name is Dr. Astrid. I am actually not a gynecologist. I'm an old people doctor. I'm geriatrician in Sengkang Hospital, but I have been treated by Dr. Andy and his team, Dr. Lim Wei also, and they have asked me to share with y'all my experience with endometriosis. So, everything that the doctors just now shared, I pretty much experienced it. Okay, so I want to just share with you from the beginning, like how it started. As far as I can remember, my journey started when I was 18 years old. So I always had this very heavy period and it was getting more and more painful. I was always tired. And now that I think about it, probably because I've lost a lot of blood at that time. And my body was always aching. And at that time, I was actually in the States. So one time, I had very, very severe pain and I was admitted to the hospital. And I remember the doctors even told me that I was not pregnant, but basically gave me some painkillers and told me nothing is wrong. So the pain went on for many, many more years. And I did not even realize that I can actually take painkiller because I thought that period pain is normal. And I thought, my mom had period pain as well. So many of my aunts had period pains as well. So I didn't think too much about it. And I thought, I would just suffer through it. So at 24 years old, I had such a severe pain before I boarded a plane. And a very kind stranger lady actually gave me Aleve. Aleve is in America, it's a form of NSAID. And this Aleve actually helped me a lot. It made the pain better. And ever since then, I actually started to take painkiller during my period. So fast forward a little bit more, when I was in medical school, I had pain all the time, every month. And sometimes even the days that I was not having my period. And this is during studying, during ward rounds, during eating lunch. Basically, pain was my friend. Sometimes pain is still my friend now. So, and I was admitted 2 times to the hospital and emergency department with pelvic pain and sometimes tummy pain. And at one point, the doctor actually told me I had appendicitis. But then when they scanned it, there was nothing on the scan. And then another time, they told me I had urinary tract infection. But I had no painful passing urine, no urinary symptoms. And at both times, they injected me with some painkiller, and then the pain got better. So what was the turning point was that one day, as a medical student, I was doing this ward round, and I had very sharp pain up to the point that I was about to pass out. And at that point, I had one teacher who was a gynecologist, and he said that, you really need to go to KKH and get yourself checked. And for the very first time, endometriosis was considered. So if you remember what Dr. Andy said on the first sharing session, endometriosis always missed most of the time. I pretty much was missed for about 10 years then, by the time that endometriosis, the word even came out from somebody. So that pain, that very sharp pain, actually, when they scanned me, they found that I had chocolate cyst and many cysts, and one of the ovarian cysts actually had ruptured. And I was actually walking around with pain and actually blood inside my tummy, So I went for the laparoscopic, the keyhole surgery, and they confirmed the diagnosis of endometriosis. And they started me on the pills, and it did help, for about 5 years. Okay, now, so after 5 years of this oral contraceptive pill, the pain is still there on and off, I did try some other medication, which is supposed to be for endometriosis, but it did not work because I had a lot of side effects. So as the years gone by, seems like the endometriosis gotten worse, and the pelvic pain was just worse. So I had to go for a second surgery, and truly the endometriosis was still there, and it was progressing. And now not only I have endometriosis, I also have a very swollen womb, I had adenomyosis as well. So at that point, they put in the IUD, which is the Mirena. And I must say IUD really did help a lot. So life carried on, I managed to, even with all the pain and whatnot, I managed to finish my training. Sometimes there was some occasional flare, but mostly quite controlled. Okay. Then last year, which is about 5 years after my first IUD was placed, I started to have pain again. And this time it was like this gnawing feeling. And this gnawing feeling was just getting worse and worse. And I was wondering, what is going on? And it started to affect my passing urine and passing motion. So when I had bowel movement, it was actually painful. And when I passed urine, it was also actually painful. So I decided at this point, I heard from my gynae friend that there is an endometriosis specialist. And luckily, I actually found Dr. Andy's team, so an endometriosis specialist. And when they scanned me, they found out that now, like what Dr. Serene showed on one of her pictures, my womb was stuck to my bowel. So I actually had deep infiltrating endometriosis, sadly. And because of that, Dr. Andy Tan and Dr. Lim Wei Wei, and the team actually had to operate on me. And it took like 5 hours robotic surgery. And afterwards, they had to put in a new Mirena. And I must say, after the surgery and the new Mirena, my quality of life did improve. So far, my pain is under control. I'm able to work hard. Most days it's quite okay. So I'm hopeful that my endometriosis will still stay stable. But I know, anything pretty much can happen with this disease, okay? So I just want to share with y'all, I don't put pictures here, but you may recognize some of the names here. So like Dr. Andy said, that 1 in 10 women, that is really a lot. And we are in Singapore, like a developed country. And these names that I presented here are names of women in America. Okay, I don't know anybody in China or celebrities in China or in England, but I studied in the States last time. So, I knew who these women are. These are really, beautiful, accomplished women. And they did a lot of good work, and they all had endometriosis. And if you look at their stories, you can Google on them. read their stories. It was actually quite inspiring. Lena Dunham, I think, had an article published in Vogue or one of the fashion magazines. And, it was just very true. What was shared during this sharing session is that all of them, they were not diagnosed early enough. They were all misdiagnosed for a time before the doctors actually arrived at the endometriosis diagnosis. But I want you all to know that, these women still, even though they have this disease, they still accomplish, they still do good work. They went on to have babies, they move on with life, So if anything that I want to share, actually, the most important thing, as it was, hammered over and over again by all the speakers, is to actually recognize it early so that you can get treatment early, be it for pain, be it for infertility or whatnot. And, you even want to mention it to the doctor. So I saw some of the questions, I'm having this period pain. Could it be this? Could it be that? I went to the A&E, but the doctor said nothing wrong with me. So you might actually want to even mention it to the doctor, because I'm sad to say this, but endometriosis, despite how common it is, people are just not aware about it. So sometimes it's even worth it to actually mention about it. So step one, awareness is so important, And if you are started on a medication, and that medication may have worked on you for a while, and then subsequently, you felt that the medication is not really working anymore, or you are suffering from side effects, you can get second opinion. Nobody's going to stop you from getting a second opinion. You can go find another gynae doctor. You can find an endometriosis specialist. You can ask to be referred to an endometriosis specialist for a second opinion. And your gynae doctor will help you find the best treatment, because as just now Dr. Lim Wei also shared with you all, there were many, many options. And you need to find one that suited you the best with the least desired side effect. And the most important thing, I think, in my journey is to try and try again until you find one that works for you. For me, for a while, it was the oral contraceptive pills, and then afterwards, it was the Mirena, For most women, I must say, seems like the recurring theme on the Q&A also is the pain. So pain seems to be shared with among all of us, okay? For some women, as you heard from Dr. Serene Lim, fertility is an issue. I just felt that, you really should start thinking about it early. So if you do have period pain and having a family, having babies is one of your, desire, I think you need to get consultation early, so that hopefully, if you do have endometriosis, it can get addressed early and you can get treated early, and then there are more options for you, But I want to just let you all know that you're really not alone in experiencing these mixed bags of feelings and emotions and issues, because there are really options to help. And the most important thing, I think, is also to be kind to yourself, be kind to your own body. I've missed so many important days because of the pain. I couldn't go to a lot of things that, it would have been fun had I gone to, but because of my pain, I just couldn't, And I think today, if anything, there are like 200 something participants here today. I hope that you all will go home, share it, pay attention to the women in your life, be it your sister, your friends, your best friend, whatever female friends you have. If they're having very bad pain, now that you got this sharing, tell them, have that light bulb in you, wonder, could she have endometriosis, Or if at work, you have friends with pelvic pain, period pain, tummy pain, there are many, many, many endometriosis patients who are suffering silently. I myself as well, because I was a medical student. So most of the time, I just took so much painkiller, until I got gastric pain. And it didn't occur to me for a long time that I have endometriosis, even as a medical student. So think about it, and help out each other, help other women, over the course of this disease, because endometriosis, just like what Dr. Serene Lim said, it's actually a really mean disease. I'm not going to lie about it. I went through a lot of negative things because of this disease, I had rejection, I was angry, I was feeling depressed, I was discriminated against because of this disease. But I think somehow I did find that through my doctors, through my gynecologist, I felt encouraged to try, of course we are afraid, but we should try not to be afraid to face it, and let's try to do something about it, and we have to accept, if anything that I can share with y'all, and I'm sure y'all also already know, is we need to accept that it's a journey. Like, there are good days, there are really bad days, there are really dark days, there are really shiny days, there are some despair days, and there are some hopeful days. But I think the most important thing is that, we should continue to try. We try to hope, and we really need to continue to move on with life, because endometriosis is just one part of our life. For me, I take it as, it's an extension of me. Like, I have this, maybe a lump somewhere on my my finger that is there, and I can never get rid of it completely, but I'm trying every day to really live with it. And it's good when you have support. So you heard from the people who shared today, all the doctors who shared with you, as well as the therapists. You need to get support from your partners as well, your family members, so that, you feel that you really can appreciate and enjoy the good days. And when the days are really painful, you just have to be kind to yourself, take a rest, and be patient on the not so good days. Yeah. So I think, again, it's good that if I want to hammer on the message, one is awareness, of course. Number two, get help, seek information. You are now much more knowledgeable than before you attend this forum. And when you seek help and you try something, and even if it doesn't work the first time, I just want to share with you, I did get discouraged. I went through 3 surgeries, and the last one was quite major. But we just have to keep trying. And, there are some good days like now. I'm talking to y'all, I am not experiencing pain. And I really enjoy these days, So I just hope that y'all can go through that as well, so that you have least amount of pain days, that you can live however one you want. And for those who really want to have babies, you get this address early, then you can get babies early, and really appreciate, your life, I think. So that's all I want to share. And I'm very thankful. Even I myself, I'm learning a lot from this session. And I think we will move on to, Q&A after this, I suppose. Yeah. Thank you so much.
All right. Thank you very much, Dr. Astrid, for the very heartwarming and wonderful journey that you've been through. Hereby, we wish you all the best in your journey, but also all the more good things will come for you. Okay, so now we have reached close to the end, but before we do that, could be a Q&A session. Right, so I know that there are a lot of questions in the Q&A. I think close to 100 questions so far since the whole session has started. And I believe that our experts and speakers have tried furiously and typing away their replies to all your questions. I think almost 2/3 of them have been answered. So if you have time, you can run through those questions that you asked. But I would just like to maybe pose one or two questions that I kind of noticed being brought up again and again in the Q&A section by different people. So maybe what we'll start off is this. Maybe the first question I'd like to direct this to Dr. Andy Tan. So maybe you can share with us, Dr. Andy, what is the difference between endometriosis and adenomyosis? And is there a difference between a stage 4 endometriosis and deep infiltrating endometriosis? Are they the same?
Okay, as I mentioned earlier, the mechanism of the endometriosis or the pathogenesis of it. So usually the accepted theory is that the deposition of the endometriosis at the pelvis, which is what we call the endometriosis, and it progressively getting worse. And concurrently, the adenomyosis, earlier on I did mention that it can happen within the womb. So this condition is called adenomyosis. So, and whether, like you said, whether the deep infiltrating endometriosis can happen concurrently, that is data to show that when you have deep endometriosis and or endometriosis, about 30% women has concurrently have adenomyosis. So, to explain the difference is that I would say it's a kind of a siblings, all right? It's like if endometriosis is actually outside, it lives outside the womb, but this siblings of endometriosis live within the womb. It's in the muscles of the womb. Yeah.
I believe there's also another question. Is this hereditary, Dr. Tan? Can it be passed from generation to generation?
Yeah. So actually data has shown that that's actually some genetic predisposition, all right? We can't pinpoint at what genetics we should screen for. However, that, as I mentioned earlier, risk factors, a family history. If you do have a family history of endometriosis, particularly if your siblings and your mother have endometriosis, yes, you are slightly on the increased risk of endometriosis. Yeah. Okay.
Thank you, Dr. Tan. Next two questions, I might want to direct this to Dr. Lim Hui Hui. Dr. Lim, so there were some queries about, in alignment with what Dr. Tan has mentioned, adenomyosis versus endometriosis. So I noticed there are a few questions that people keep asking. Is there a difference in terms of the treatment?
Okay, so actually there's quite a huge overlap of treatment between adenomyosis as well as endometriosis. So adenomyosis, you tend to present with heavy menses as well as painful menses as well. So analgesia, which I've mentioned earlier, like non-steroidals, can actually help with the painful menses. And heavy menses, you can also use hormonal therapy like COCPs and progestogens as well to help. So there is a huge overlap. Surgery-wise, instead of targeting the endometriotic deposits, if there is a focal growth like an adenomyoma, then that can possibly be also targeted as well during the surgery. And of course, lastly, definitive treatment, if fertility is not a concern as well, and no other medical treatments or any other conservative management helps, then a hysterectomy would be the definitive management.
Okay, thank you. And there's this other question, I think, that I think the audience have actually raised. If one has an endometriotic cyst, do you need to treat it? Or can we just leave it alone and hope that it goes away miraculously on its own?
Okay, so endometriotic cyst, it also depends on the size of the cyst and whether there's any symptoms. So, for example, if the size is large or if there are any features of any malignant change or any cancerous features, then definitely surgery would be recommended for sort of histology purposes to exclude any cancers. And however, what Dr. Serene mentioned as well, one has to be very careful about doing surgeries on the ovaries, because removing endometriotic cysts can reduce your ovarian reserve, because some ovarian tissues will definitely be taken out even if one is very careful during the surgery. and this can then result in subfertility in the future as well, and reduce egg count. But of course, if the large cyst can also be a problem if you do IVF, because it does hinder the egg retrieval as well. So this also has to be, is very individualized per patient, and it also depends on the size and what symptoms this cyst is causing. So if you do have one, then you do need to get a scan and seek your gynae advice.
Okay, thank you, Dr. Lim. All right, I think there's a lot of interest in this Visan or Visane, depending on where you come from pronouncing this word. If you're French, you call it Visane, Asians call it Visan, whichever, doesn't matter. But this is otherwise known as Gynaecology, I believe. So maybe we can get some, insight as to what this medication is for, because I think there are a lot of questions surrounding this medication and how long can one use, and for what particular indications. Maybe Dr. Lim or Dr. Andy Tan can take this question.
Okay, Visan, as I mentioned, is the name itself. It's a progestin. It's called Gynaecology. So there has been a lot of studies on it, and progestin so far, why it is a theory is actually to mimic the milieux of someone who is pregnant with a high progesterone. So that's why progestin has been kind of that's the recommended treatment for endometriosis. And if I'm not wrong, so that's what evidence has there. So that's this study is called a VICO study. So in Europe, that's a collection of all the patients who's on Visan or Gynaecology. So far has been a safety profile of up to 7 years, and a safety profile in the sense that we'll look at, is there any increased risk of, for example, breast cancer, is there any risk of worsening depressions, and of course the bone loss and all that. So overall, the data has been promising. So there's no strong evidence that it increases all this. And in terms of the bone loss, similar to other progesterone, that's a small risk, but of course with lifestyle modification, that it is not a big concern. Yeah.
Okay, thank you, Dr. Tan. Dr. Lim Hui, do you have anything to add?
No, I agree. And also,
okay, sure.
So you can just use it long term, as far as you're aware. Yeah.
Okay, thank you, Dr. Lim. All right. Next, there are a couple of questions directed for Ms. Ip Wan Hui. Right, Ms. Ip. There was a question about pelvic floor pain and something to do with pelvic floor dysfunction. Right? How can one train or even assess the integrity of this pelvic floor dysfunction issue, especially the muscle, I must say?
Typically, if we are looking at assessing the pelvic floor specifically for pain, not just for strength and function, then definitely an internal examination as tolerated is the most accurate. But as with anyone who is experiencing pain, especially in such a private area, a physical examination can be fairly daunting. So usually on the first session, we don't embark on an internal examination if the person seeking treatment is not comfortable. Generally, we have things like the real-time ultrasound machine that we can look into the body and look at how well the muscle is moving and relaxing externally. So without actually physically touching the area that is painful. But I must say that there are limitations with external forms of examination because we are unable to feel what we call the tone of the muscle. So what I was saying in terms of how tense the muscle is at rest. Visually, we can examine the quality of the movement. Basically, how can the patient tighten, and is the patient then able to relax well? Is the relaxation complete? Is it a smooth relaxation, or do they have to spend lots of time breathing and then trying to distract themselves in order to let go of this part of the body? Because if they do present like that, then it just tells us that there is a higher chance that tension within the pelvic floor can potentially be contributing to the symptoms that they feel, whether or not the pain is felt during intercourse. And then we treat it basically from there. Is it difficulty relaxing? Is it fear? Is it stress? Is it poor sleep? What it is? Yes, so the treatment really depends. Like everyone has been saying, it needs to be individualized.
Thank you, Ms. Ip. So when we talk about pain, from the angle or the perspective of the physiotherapy and your expertise, how do one judge or know that this pain is endometriosis pain, or this pain is just a muscular pain, or is this even just a simple nerve pain? Yeah. Particularly below all this.
Okay, so honestly speaking, we don't really make that judgment. What we do is whether or not we can reproduce the pain. So if the pain is from the muscle, then there are usually certain patterns. If I press on the muscle and the muscle is not relaxing, does that reproduce the pain? The specific kind of pain experienced by the patient, and the patient is complaining about it. If I am pressing and I'm causing pain, but the pain is external, however, the patient came here for pain that is deep within the pelvis, then I would say, yes, perhaps, something can be done to improve the muscle and reduce the pain externally, but the muscle then might, or at least this particular muscle that I'm touching, might not be the cause of that internal pain that the patient came complaining of initially lah. And there are certain patterns. So like I've mentioned during the talk, some people have more pain with intercourse at specific times of their cycle. Generally, if the pain does present with this kind of cyclical pattern, then we might say, yes, it might have something to do with the hormonal cycle of endometriosis. But then again, because I'm a therapist, so I deal more with the physical components. What we might then advise is, okay, if you've already noticed this pattern, then what we might do is you might then take it easy for this particular part of the cycle that you've noticed that you're more tender. So it's more of a therapy in that way. It's almost like you're managing your lifestyle, still trying to get quality of life while managing with this condition.
Okay, thank you, Ms. Ip. We're going to have two more questions, and I'd like Dr. Serene Lim to help us with this. Right, Dr. Serene Lim. There was a lot of interest in the hormonal treatment for endometriosis. So there was one particular interesting question that was asking, if someone is on hormonal treatment for endometriosis, when is a good time to stop, or even is there a chance to stop when you're thinking of conceiving? And obviously, if you do stop, you might worry about this endometriosis recurring, the pain coming back again, like what Dr. Andy mentioned in his slide previously. So maybe you can share with the audience your thoughts on this, especially in the perspective of trying to conceive with this condition known as endometriosis.
So I would suggest to continue hormonal treatment until you are ready to get pregnant. After you make a decision to start trying for baby and stop hormonal treatment, I would suggest to get checked early. I'm not saying that you have to get checks like immediately after starting hormonal treatment. You can give yourself a couple of months, to try naturally and see if you fall pregnant naturally. It doesn't mean that just because you have endometriosis, you won't be able to get pregnant on your own. But I suggest after about 4 to 6 months of trying and you haven't succeeded, perhaps do see a gynecologist to do some basic fertility tests. It might not always be due to the endometriosis. Many couples do have a combination of infertility factors, so don't always point fingers at yourself. It may be your husband. So what I'm saying is that so after about 4 to 6 months of trying and nothing happens, I suggest do get checked early, and so that you can move on to fertility treatment or surgery early and get pregnant before your endometriosis comes back.
Okay, thank you, Dr. Serene. Point well taken for gentlemen or like us out there. Okay, there is another question about adenomyosis. So if one has existing adenomyosis, can endometriosis be a double whammy in affecting your chances of conceiving?
Well, adenomyosis is essentially endometriosis involving the uterus. You can have adenomyosis occurring in isolation, but very often when there's adenomyosis, there's also usually endometriosis. So if there's adenomyosis seen on the scan, chances are there's also endometriosis that will act in combination with the adenomyosis to affect your fertility.
Okay, thank you, Dr. Lim. One other question, I think that's weighing on everybody's mind. I think when I look at all the series of questions, I think a lot of people have undergone and undertaken surgeries in the past, either keyhole surgery or open surgery, and the big question is, how many times or surgeries can one undertake in a lifetime for endometriosis?
So, well, surgery, as I mentioned, does have its complications. I don't think there is a maximum number. When I did my in fertility preservation in Australia, I saw some patients who went for 16 surgeries for endometriosis. I kid you not, 16. So, I don't think there's a maximum number, but my advice is to, if you can, try to avoid having surgery for endometriosis if you can, or if you need to go for surgery, try to make sure that that is your only surgery that you ever need for endometriosis in your life.
Okay, thank you, Dr. Serene Lim. There's another, I think if I may just summarize, there's this question of pregnancy and endometriosis. Okay, so maybe anyone in the panelists can take up this question. I think question number one is that when one has a history of endometriosis and, with a stroke of luck, conceive, have a baby, what happens thereafter, right? Will it come back again? And how soon will it come back again? Will it be back with a vengeance for that matter? Anyone in the panelists?
So I think that this is very individualized. I've seen patients where their endometriosis kind of like gets cured after they got pregnant and had a baby. But there are also other patients who got pregnant and the endometriosis did come back quite quickly. I think one thing that you can do to try to stave off the endometriosis is you can try to breastfeed, because the breastfeeding breastfeeding does have a suppression effect on endometriosis, So if you imagine pregnancy is usually about 40 weeks, about 10 months. So you are free from endometriosis for about 10 months. And after you deliver, if you breastfeed for say about 1.5 to 2 years, it means a total of almost 3 years of being free from endometriosis. So I think that's quite significant.
Okay, thank you, Dr. Serene Lim. Anybody has any comments to add on that? I think there are a lot of interest in this area.
So I do have patients, after pregnancy. In fact, they have never encountered any pain before the pregnancy, and they never know they have endometriosis. So it's kind of got worsened after the pregnancy. So nobody really knows what the mechanism, as I mentioned earlier, but we understand that endometriosis is estrogen dependent, and the symptoms really varies. And some have seen severe endometriosis, had non-symptoms with large endometrioma, but some with really just a peritoneal endometriosis, like just a superficial, and it causes so much pain and all that. So, and I would say, all in all, this is really have to be customized. And if that's after pregnancy, if let's say they still wish to get pregnant, I think we need to tailor how to help them to continue to get pregnant. If the pain is the main symptoms, then yes, then we will have to plan it out, do surgery, and do a long-term test. As I mentioned earlier, it's a chronic condition, at least until the menopause. And I would say some will disagree, say that the menopause is not the final destination, because if there is fibrosis, I did treat some of the postmenopausal women who had endometriosis surgery prior to their menopause, and the fibrosis were left behind. And this fibrosis that cause scarring can subsequently cause problems such as chronic constipation, and where they cannot pass motion. In fact, they have to resect the bowel from there. So it is a long-term management rather than just on a specific amount of time. So I would usually take this as analogy as you being diagnosed as diabetes. You wouldn't want to suddenly say you want to stop all the medication and your diabetes get worsened. So it is a long-term plan, how in the phase of your life, what you want to do. And yeah, that's probably what I want.
Okay. Thank you, Dr. Tan. Yeah, perhaps we have time for just one last question. In the interest of time, yeah. Fibroids and endometriosis or adenomyosis, right? What's the difference and how do you all deal with it? Can they be related? Do they have an impact on each other? Anybody in the panelists would like to take up this challenge?
No, sorry, what was the question again?
Okay, somebody was asking about having a fibroids and a bulky uterus suspicious of adenomyosis, right? How do you pick this up? And how do you actually treat it?
Okay, first of all, as we know, fibroids is one of the commonest benign conditions for women. All right, it can cause a lot of symptoms ranging from heavy menstrual bleeding up to can cause a pain. Of course, then it also can cause symptomatic problems such as compression and bladder. So as compared to adenomyosis, first actually the diagnosis itself, I think from ultrasound, there's actually the features that can suggest endometriosis, and of course some features can suggest adenomyosis. And the treatment should be, as again, customized to first the age, all right? So if it's a fibroid is big, and what is your priority? Is it the symptoms or is it the pregnancy? So this is a very difficult question if it's just based on this and what will you do. So it has to be all collective. What is the age and what is the priority? Is it having a symptoms or if she's been trying to get pregnant and what are the things? So just by itself, just fibroids, adenomyosis, what treatment should be done? It's difficult to answer at this way. So I think if you do have this, then we need to sit down and do a very detailed discussion, as because if you do want to remove the fibroids or doing a removal adenomyosis, there of course got implications from there if you want to get pregnant, such as risk of ruptures and all that. So I wouldn't have one definite answer for this, but it's a good question,
Okay, thank you, panelists and esteemed speakers, and definitely our patient advocate, Dr. Astrid. Hereby, I think if I may take this last couple of closing moments to just summarize from what I understand from today's series of talks. I think first and foremost, the main objective of this talk is to bring about increased awareness about this complex condition known as endometriosis. As you have heard from all our expert panels, it is a common enough condition. In fact, it's becoming more common, right? Ladies, women are coming forward, and even younger ladies are coming forward to ask, do I have endometriosis? And that is a very, very good move, because awareness is very important, as highlighted by Dr. Astrid. And I think the second take-home message is that it is important to talk to your doctor. Find the right doctor, isn't it, Dr. Astrid? Yeah? You must find the right doctor to talk to when it comes to endometriosis, because it is not an easy condition to deal with. And definitely in line with this, that brings me to the third point or third take-home message is that because it's so complicated, right? There are so many facets, it's so many areas. It is important that your treatment is being tailored and individualized, right? No one is the same, right? I believe Dr. Lim Hui Hui, Dr. Andy Tan, Dr. Serene Lim, Ms. Ip will agree with me that this is more of a multifaceted condition that requires a more multidisciplinary form of input and collaboration. And this is something that is available in SGH, ONG. So feel free to come to us and contact us if you need to seek any questions, any help. Our doors are always open. Okay, so this brings me to the final closing moments of today's public forum. Firstly, I'd like to take this opportunity to thank 3 groups of individuals. The first one, obviously, would be our distinguished and esteemed speakers or panelists, Dr. Andy Tan, Dr. Lim Hui Hui, Ms. Ip Wan Hui, Dr. Serene Lim, and our patient advocate, Dr. Astrid, for taking the opportunity here to share with us all your insights on endometriosis. And the second group that I'd like to thank would be all of you, audience out there. Thank you for taking time off on a busy schedule of a Friday afternoon to come and join us in today's symposium. And I'd like to also finally thank our sponsor, Bayer, for your generous support for today's event. So with this, I will bring this session to a close. So goodbye and stay safe always. See you during the next symposium. Bye-bye.